Welcome to the Soul of Medicine. Hi, everybody. Welcome. We have Dr. Brian Licuanan with us. Hi, Brian. Dr.
Hello,
Brian.
how are you? How are you?
Yes, good. So glad you're here. So I was really excited to see all your path and all the accomplishments that you've done in these last 3 decades. And I just wanted to, one, invite you on to talk about your path and what we just said before, finding your pocket, and talk about some of the cool things that you're doing. So welcome.
Yes, thank you. Thank you again. And it's great that what you're doing as well, both of you are doing and spreading medical and men's health awareness. So I think it's great. I'm glad we lined up with that. And it's important out there. And the reach is great too with social media now and podcasts. The reach is really, really able to connect with a lot of people. So I want to send that your way as well.
Thank you. So let me introduce Dr. Licuanan. He is a board certified psychologist with nearly 20 years of experience working with diverse populations, from individuals and families to organizations and communities. He specializes in treating a wide variety of issues with a particular focus on substance addiction and cognitive behavioral therapy for anxiety and insomnia, sleep disorders. Dr. Licuanan is a sought-after speaker, educator, and author who empowers families to combat mental health and addiction. He has written a guide for families navigating the challenges of treatment, offering actionable steps and guidance. And he competes in Brazilian Jiu-Jitsu. He believes the importance of a sound mind, body, and spirit. Welcome.
Thank you. Thank you again.
I love that last sentence. That is really cool because I think, even in medicine and psychology, this holistic viewpoint and way of being is, to us, the way to approach everything.
Yes, for sure. I work with a lot of clients on, I believe, 4 major areas of one's better living. And if someone's struggling, most likely one or more of those areas are deficient or need more attending to. And it's the physical self, right? What we do with our body, how we treat our body. And then there's the mental or emotional self. Then there's the social self, and that's career, relationships, extracurricular activities. And then there's the spiritual part, and spiritual part can mean a higher power, a God, but it can also mean just a deeper purpose and meaning. And usually those are the 4 major areas where I see that people are attending to and that they're thriving. And when someone's struggling, chances are most likely one or more of those areas are being neglected or not being focused on. So,
have you noticed in the last few years, even of your practice, that a lot of people are coming to you for this spiritual higher power, deeper meaning? Tell me the root cause. I think it's more than what I feel in my body or what I think in my head. In my practice, I've noticed in the last maybe 4 or 5 years, particularly since COVID, when people had this opportunity to sit still, even had trauma and tragedy happen in their lives, they're starting to make this deeper connection and wanting to know something else. So how does that in your practice present with your clients, asking maybe that spiritual component?
well, to answer your question, do clients come into me directly saying, in more words or less, that I need to work on my spiritual component, meaning I'm having struggles with finding a higher power, or I have struggles with finding purpose and meaning? It's actually a byproduct of the original issues they're coming to see me for: depression, anxiety, whether it be insomnia, substance use, relationship issues. And as we kind of deconstruct what's going on with them, the spirituality component usually surfaces, because a lot of them who are struggling with depression struggle with areas such as motivation in life. And you find out that self-worth and what is their purpose and meaning in life are very, very consistent across the board. And so, yes, it does come up, but not as a direct complaint or a struggle. And it's really powerful to see when people start to realize that. I've had people who are either atheist, agnostic, or have a strong connection they believe with, for example, their spirit, and people that were atheists come out of the treatment like maybe there is something greater out there. People who are agnostic saying, you know what, maybe there is a God of some sort, or people that had some spiritual connection sort of re-enhance that intimate relationship. And so, but it's a very, very common area that I like to focus on. And I think it's a difference maker in people's lives when they start to realize, okay, this is my purpose. This is why I'm here. And this is what I'm striving for.
Thank you for doing that. I mean, I think that is so key, that you have the ability to hold that space and actually go there and maybe inquire as one of your pillars, important pillars to the whole picture. And I think sometimes, particularly in clinical work or even medicine, that's one, we don't have time to go down there or make that a priority, where I feel, and my practice is called Soul of Medicine, that kind of connection ultimately begins or is the root of a lot of the physical. And I always say that physical is the caboose, it's not the cause. So of course you don't hang your shingle up there and just say like spiritual surgery, that's not how people usually present. But to be able to inquire about that, hold space around that is, to me, I find invaluable. So that's amazing.
Thank you. Yes, because it's just an avenue that people haven't thought about, or or something that they've just been very confused about. And you're right, we don't go in there and this is a belief system that you have to adapt. One of the things we learn as clinicians as unconditional positive regard, unconditional acceptance, and be present to where they're at. And you get sometimes people, when you talk about those things, clients can be very uneasy with it. And I tell them very specifically that, spirituality just means a deeper sense of purpose in the spirit or the soul part that you refer to. And it really kind of takes away a little bit of that pressure for them to feel the need to attach to something of like a God of some sort is. And so, but yes, I think you use great words as providing that space. And that's what we do, is provide them that space to on this self-discovery. So
awesome. Okay. That was a very heavy question to start out with. So let's back a little bit. Dr. Brian, can you share with us what initially drew you to the field of psychology?
That's a good warm-up.
Yeah. Everything's downhill from here. It's all good.
It was not a straight path for me. I always knew that being of service to others was the route I wanted to embark upon. I just did not know the right path or journey to take. And so medical school, being a biology major, psychology major, were some of the routes that I had embarked upon, and I just couldn't get the stick. And I do believe that things are laid out on our path somehow or for some reason. And through various mazes and so forth, and through some work in working in the psychology arena, I decided to pursue it on a graduate school level. And it wasn't even originally in this field. It was in another field that looked at behavior in the workplace called industrial organizational psychology. And it just wasn't a good fit for me. It's a great field. A lot of it's data analysis. They're human resource directors. And I just transitioned to the clinical program. And I said, wow, there's nothing like it when you find home, so to speak. And at least on the career level, I feel like this is home for me. And it's just really in line with kind of my belief systems, my values, my skill set. And, when you're passionate about something, it just comes naturally. And I'm always looking for that next level. And coming on podcasts and spreading mental health awareness, I believe, is the next level of what I feel like I can contribute to the field.
So I'm just making an observation here about you two being therapist, coach, functional medicine practitioner, and you said something that was really interesting and I think important, that when you find that pocket, when you are preaching the things that you do, Rob does that quite a bit in his, and as I've known him, he is a good coach because he practices what he preaches. So it's nice to see that embodiment of the things that you guys are talking about.
I do have a question, but I also recognize in what Brian said is, always looking for that next level. So oftentimes it's a layering on what you love and you enjoy, and you're almost like, I don't know if you would agree, but you're almost discovering yet another avenue, facet that just makes things even better and greater and more enjoyable.
Mm-hmm. Mm-hmm. And then you add on of being of service to others and impacting other people. To me, that just adds a next level of impact and satisfaction on my end.
So let's talk about CBT for a second, cognitive behavioral therapy. So for our listeners who may not be familiar, could you explain what CBT is and how it works?
CBT stands for cognitive behavioral treatment, and it is one of the most researched treatment modalities. And the belief system behind CBT, we'll say for short, is basically how we think has an impact on how we feel and eventually behave. And changing our thought patterns, changing our behaviors can eventually have an impact on how we feel and eventually outcomes of our behaviors. And some of the beliefs that cognitive behavioral therapy believes in is we harbor what we call these core beliefs. Core, like a center of a apple core or center of the earth, are these belief systems that we hold to be true no matter what. We can have healthy, positive core beliefs. Where most people struggle is they harbor negative, irrational, or what we call automatic negative thoughts, all the same stuff. And that has a really huge impact on eventually how the outcomes of the behaviors and so forth. And so cognitive behavioral therapy on many levels sorts to reframe and those negative thought patterns. And then there's CBT for many things. There's anxiety, gambling, alcoholism, drug abuse, almost anything, depression. And it's you see that at least the principles of it integrated across many modalities. So that is CBT very, very broadly in a nutshell.
So you are also skilled for CBT for sleep, correct? And I'm so interested in this because I was reading on it and I'm like, this is exactly what I've been trying to tell my patients. I didn't really have the words to say it. So could you discuss more of that? CBT specifically addresses sleep disorders like insomnia and what makes it an effective treatment approach.
Okay, yeah. So the full name is Cognitive Behavioral Treatment for Insomnia, and I'll refer to it as CBT-I moving forward. And just to back up a little bit, because a lot of people have these sort of misconceptions or maybe just naive knowledge of what insomnia is. People usually think it is not being able to fall asleep looking at the ceiling all night long. That can be one symptom of insomnia, but it also can be waking up in the middle of the night, right? And inability to fall back asleep, or just waking up too early to your target wake up time. And so having one or more of those for a period of time, multiple times a week for at least 1 month, and it's not because of substance abuse or any other medical conditions, you probably have some form of primary insomnia or some type of insomnia. So I just want to highlight that as well of what insomnia is. But CBT-I is a manualized treatment that is designed to actually cure insomnia. And the belief behind CBT-I is that people are spending too much time in bed, not sleeping, and they're engaging in behaviors that perpetuates the non-sleep. And so 3 main areas of focus for CBT-I to actually cure insomnia are, number 1, sleep hygiene. Sleep hygiene are just these instructions to why people struggle to sleep or instructions to help people sleep better. We could talk a little bit more about what some of those examples are later on. And then there's stimulus control, which is basically this association. People who have chronic insomnia no longer is sleep or bedtime associated with serenity, peacefulness, and restorative sleep. It is with anxiety, frustration, resentment, and they actually resent nighttime and bedtime. And then the last part is sleep restriction. I know it's a paradox, right? Sleep restriction, I'm coming to see you to get more sleep, and then you're going to restrict my sleep. But no, what it's doing is it is capitalizing by adjusting people's bedtimes and wake times to maximize what we call sleep pressure. Sleep pressure or sleep drive is just this level of sleepiness. And a lot of times what we find are people are spending too much in time awake. And for example, if your bedtime's 10 p.m. and your wake up time's at 6 a.m., right, what we call your sleep opportunity is 8 hours. A lot of times people aren't sleeping close to 8 hours. When we look at it, they're sleeping 3 hours. That other 5 hours they're engaging in, sleeping in bed, tossing and turning, watching TV, all perpetuates the non-sleep. And so what we do is we constrict that sleep and bedtime to maximize how much time they're really sleeping, and then eventually open up that sleep opportunity time as they are starting to get sleep. And so the reason why CBT-I is very effective is it's dealing with their natural ability to sleep. Circadian rhythms, a 24-hour clock. What's happened is their clock has shifted for whatever reason. They're staying up late, whether it be they're gaming, they're just staying up, they work a graveyard shift. Their work lends itself to that. Residents, right? Medical residents. I'm sure sleep is not that smooth and it's interrupted and sleep shifts and so forth. And so that's what it does. And assuming CBT-I is appropriate when there's no other co-occurring medical or psychiatric conditions at a high level that aren't being treated. So we have to make sure that at least if there's anything else going on that level, it's at least being attended to or treated. So that is CBT-I in a nutshell.
I see Rob squirming in his chair over there. So one thing that we come across with our patients, and we ask them, is your mind racing at night? And they have these what seemingly inappropriate cortisol secretions that keep them up, and these sort of ruminations, and it's almost like they're going 100 miles per hour during the day. They close their eyes and it seems like they're processing everything through the day, right? So we can most of the time successfully drop those cortisol levels at night for a time until the next stressor comes in. So I find that this might be something to go deeper into that, because it almost feels like their body can't let go or they can't let go, because I find that sleep and nighttime is this opportunity for surrender, of letting go and not being hypervigilant, that I am going to wake up in the morning, you know what I mean? And everything's going to be okay. But with all the stimuli during the day and the worries and the things to wake up to, I think there's a lot going through one's psyche, so why would they rest? So is that something that CBT-I addresses on a deeper level?
Well, I can tell you this roughly. When people come to me, they're referred to me. A lot of times, just to mention, usually having a sleep study done at a sleep lab is very important, because what it could do is it can rule out, of course, also seeing a primary care doctor, because it's very difficult to work on sleep if you have some urinary bladder issue that's untreated, right? It's very hard to get consolidated sleep if you're urinating throughout the night, or you have some type of sleep disorder, whether it be an apnea, whether it be a periodic limb movement or sleep talk or what have you. And so we want to definitely rule those out. And usually doctors pulmonologists who also specialize in sleep, they usually have patients go through some type of sleep study to rule out any co-occurring medical conditions before they refer them to CBT-I. And so, but a lot of times when they come to me, I would say about 80% of the time, that's the great thing of what I do as a psychologist and specialize in CBT-I, is you find that a lot of at least some of their sleep issues can be attributed to some type of mental health issue. It could be a relationship issue, stress at work, some type of issue on that. And a lot of times we transition first to working on a little bit of those mental health issues before we go strictly into CBT-I. And so, yes, a lot of it, I was working with some gentleman before he came to see me, had difficulty sleeping. And then as I was talking to him in the intake session, him and his wife were fighting every night, every night, every night, every night, and it wouldn't change. And I said, well, until we sort of address that, there's not much we can do on a CBT-I level if that situation continues to happen. And so we processed that first and came up with some ideas to mitigate some of that interpersonal interaction to be able to be more CBT-I, be more conducive to being effective. Or if I've had a client who was doing sales and she was so stretched thin, she was very unhappy in her company. And we tried to look at other things, like, can you transition to another department? Did you talk to your boss? You tried everything. I said, until you get probably a transition to a job, it's going to be very hard to effectively work on your insomnia. And she did. And we were able to effectively work with CBT-I after she got a job that was more in line with kind of her values and principles. So yes, absolutely. To answer your question, a lot of times there are some co-occurring, almost always, mental health condition that needs to be at least addressed, acknowledged, or worked on prior for CBT-I to be most appropriate.
Yeah, I was going to say something very in line with what you were saying. Part of our practice is we might use supplements for people for a transitional period, and it's the inhibitory neurotransmitters that really help a lot, which would suggest their nervous systems be very stimulated during the daytime. So it is that process of kind of training that to go down, where from our point of view, supplements would help with that. But I would think, as you were just saying, those lifestyle things, all the other containers that are stimulating them throughout the day. Just curious, as their data or anecdotally, has things increased a lot since people were able to bring their TVs and their computers to bed with them?
Yes, and that is definitely a confounding variable to exacerbating insomnia, right? Because as we know that there's a structure called the suprachiasmatic nucleus, which is a little organism that sits above the optic nerve that's sort of our sleep center that detects the presence or absence of light. And when it does detect the presence or absence of the light, it communicates to the pineal gland to secrete melatonin, which is obviously the chemical for inducing sleep. And computers and phones emit blue light, which mimics that type of light that tells the nucleus that, oh, it's wakeful time. And so it doesn't release melatonin. And so, yes. And then also just activity. And if you're watching something that's action packed or provocative news, your brain is stimulating. I call it data. When you're introducing new data late at night, our brain has to process that information. It consolidates it, differentiating whether it has to go to short-term or long-term memory. And so when we're engaging in very, very active mental activity, it could really, really heighten the ability to not sleep. And so that's why low-level activities, low-level reading under low level of light to help you get in that relaxed state is very important. But if I may say something too, Robert, is with the pharmaceutical part is amazingly CBT-I, which has been researched quite extensively, has been shown to be as effective at inducing sleep as things of sleep hypnotics and so forth. But what happens though is, of course, with sleep medications, there becomes a dependence and actually interrupts the sleep cycles. But they've shown that CBT-I, when you stop practicing CBT-I, that its effects can last up to a year. And that's how robust these effectiveness are. And so, yes, definitely. And, there's some medications that are really, really challenging and people get dependent on them. And of course, in any medications, you develop a tolerance, you need more of it, then it becomes counterproductive and so forth. So,
What's interesting with that too, like the benzos that people might be prescribed, they actually deplete melatonin from the body. So not only are they dependent, not only are they not helping the person train themselves, but it's actually taking that, it's like they're looking at a blue light all night,
Exactly. And yeah, especially the benzo, you bring that up. It's a really, really huge issue. We have seen major increases, even starting in 2008 during the financial crash. And of course, with the pandemic, sleep meds, anxiety, antidepressants, and insomnia has greatly heightened, coupled with anxiety, depression. So people have become dependent on it. And so I'm hoping your listeners understand that, hey, there are other options out there, an option like a treatment like this. And a lot of times it is because we're engaging in behaviors that perpetuates the non-sleep. And so,
do you recommend any other alternative things to go with, like binaural beats, like those music or lavender infusions? Or
there's a lot. There's valerian root. There's lavender. There's a lot of natural stuff out there that helps induce sleep. And just another thing too, like for example, speaking of consuming something, people think, well, I can't eat before I go to bed. It'll keep me up. No, it's not really when you eat. It's what you eat, of course, right? You don't want to eat spicy foods because it causes gastric reflux. You don't want to be drinking a lot of liquids. That's, by the way, just to let you know, draining a bladder is one of the most common interventions that I give for people. I ask people a lot of times like, oh God, I couldn't sleep. I was getting up to urinate like 4 times. I'll say, okay, assuming they don't have a urinary bladder issue or some type of prostate issue or anything going on like that. And I said, okay, well, then I asked them how much is their output? Very little. And so what happens is they've developed this waking mechanism to wake up. And so people think, well, gosh, I'm going to be dehydrated. I said, no. I said, you drink earlier in the day, but start emptying your bladder and greatly reduce your fluid intake a few hours before bedtime. I remind them that the majority of our body is made up of water. You're not going to get dehydrated. And I said, if you get cotton mouth, rinse mouth with water, take a small shot of water or something of that nature. But so that's one of the most common interventions I give is limit liquid intake and start draining your bladder earlier in the evening. But you're right, Robert, the electronics and all of those things are huge factors that perpetuate non-sleep. And the bed is for sleep and intimacy only. That's the way to think about it. Sleep and intimacy only. And be honest with you, the intimacy also has to be pleasant. If intimacy is not pleasant for whatever reason, then you start associating the bed with negative feelings. And I actually had a client with that where physical intimacy was not a positive experience, and she had difficult with the insomnia. And so, yes, so it is for sleep and intimacy. And as long as, the intimacy is a positive experience as well.
Those are good questions. No, I'm just trying to think of I think it sounds better when it comes from your mouth than when it comes from my mouth when I try to tell them these things. And maybe I'm not approaching it the right way. So yes, that relationship, I like what you said about there's stuff they're picking up and going on that's interrupting this ability to, like I said, to let go, rest, allow your cortisol levels to chill out. But if you're on hyperdrive, it's just really hard to do that because, I was just thinking what you're saying about urinating all night long. I mean, which could be a aldosterone issue running that HPA axis down that pregnenolone pathway. But I can see how it can trigger a lot of my patients like, oh, I need to pee. I have diabetes. Then they go down that rabbit hole and makes the cortisol go up again. And then you're never going to sleep. So how quick I think people are hijacked, with that. And I think what you're saying, even having daily practices of mindfulness and relaxation on a consistent basis to lower that threshold, I think is also really important versus trying to fix it when you're hijacked already. By the time we're needing supplements and medications and alcohol and drugs to make us go asleep, there's a lot of other lifestyle things that we need to address.
For sure. And that preparation you talk about there, I talked about that there's that preparation for bedtime. That's not the time to go work out and raise your body temperature. That's not the time to engage in, like I said, an argument or anything of that nature. And so there has to be that preparation that can come in mindfulness skills, meditation, prayer. All of those things are really, really good practices. And there's other things as well, making a list of things, because a lot of times if we have a bunch of things to do the next day, we're going to run that in our head. And so having a list beside your bed, write all that stuff down, can be a really important intervention for many people as well. And then, of course, sleep environment's critical, right? Typically, we sleep best at cooler temperatures, 66 to 69 degrees. You want quiet noise, light. We don't want light coming in. And even pets. I know we all have dogs here, but remember, a lot of people believe that when we're asleep, that our brain shuts down. No, it's still attending to information. So when people fall asleep with music on or with the TV on, their brain is still attending to that stimuli. And so they don't get into that deep sleep mode. And so even a cat purring, a dog ruffling around with his or her leash coming up on the bed is disrupted sleep. And of course, also snoring is a really, really huge problem where your bed partner can't get good sleep. Even though they're sleeping, you can still attend to that. Your brain is still attending to that information and data. And so you mentioned earlier diurnal beats or white noise. I think white noise is really, really important because it can drown out a lot of other sounds if they're there in your sleep environment. And some of the best sleep for me is when I have a white noise machine playing in the background because it's consistent. Your brain will tune that information out because it's consistent. So there's quite a bit of things that we can do. There's a lot of activities that happen in our night. A lot of times sleep issues are identified by a bed partner. I get a lot of people like, oh my God, do you know you snore? I'm talking about like clients who a friend or roommate or a romantic partner tell them, do you realize that you jerk movement, periodic limb movement every few seconds? And those are actually sleep conditions. And even sleepwalking, people don't realize that they engage or do it sometimes to some level. So there's quite a few things out there. And so a sleep study is really, really important to sort of rule those conditions out.
That's really interesting. So we had this holistic dentist on a few weeks ago, and she was saying something about the palate, getting all that dental work and the arch really high, compressing and obstructing the nasal passages, and which was really, I didn't even think about that. But
I remember I was training in Kansas City, Missouri with a pulmonologist specialized in sleep. And so I was going there and just sort of trying to get some experience with sleep issues. And, she didn't really brief me on what the protocol was. And she would go in there and the first thing she would ask all the patients were, let me see your tongue. Let me see your tongue. Let me see your tongue. And what she was gauging was the size of the tongue, because the size of the tongue can create obstructive sleep apnea. And so if Gene Simmons is known to have a big tongue, right? And obstructive sleep apnea. So things like that, even enlarged uvula can create some type of that adenoids and so forth. So even the structure, deviate septum can create problems with breathing and sleep. So there's a lot of architectural things that go on that can impair that. But yeah, I thought that was really interesting. The size of the tongue is really important for that airway flow.
What about like cravings, night eating syndrome? People can consume like almost 50% of their calories in a day and they're eating at nighttime. Do you see that a lot?
Yeah. So that's a real actual sleep disorder where people have woken up and there's wrappers and crumbs or they're gaining weight and they're actually waking up and engaging in sleep eating behaviors. I mean, you could YouTube it and you'll see partners or spouses filming their loved one. They have no idea. And you would just think, oh my God, they're just eating.
I had no idea that I had that pizza. Just kidding.
Well, you need a sleep study to confirm if you have that condition. But yeah, no, people do, and they eat. I remember I did have a client in the residential treatment center, and I was his clinician, and the staff members would get me. They're very stressed, is because you know what? He keeps eating a big bowl of cereal, and we try to talk to him, tell him you're supposed to be asleep, and he would just ignore them, and they thought he was just being very disrespectful and non-compliant. But I would talk to him. He said he had no recollection. So I do believe he had nighttime eating disorder. And so a lot of times these sleep disorders are stress-induced. Substances, withdrawal from substances can create some of these sleep disorder issues. And so it resolved after a while, after he sort of got a baseline with his mental health and got stabilized from his substance withdrawals. But yeah, you want to hear another sleep disorder that's very unique that people don't know about? I don't know if you heard it before, but it's real. And it's a real topic, but it's sexsomnia, sleep sex. It's when people engage in sexual behaviors without knowing it. There were cases in Canada and I believe in New York where people were engaging in sexual behaviors with people and had no recollection of it. And so actually, I think Law and Order did a whole segment on it of a person being charged with abuse on a child. And it was determined that under medical evaluation that he actually had sleep sex disorder. So it's a lot of things that happen, and so it's real stuff. So
Interesting. So let's talk about your new book. How to Get Your Resisting Loved One into Treatment, a step-by-step plan for mental health and or addiction crisis. Wow. So tell us what inspired you to write it and what can readers expect to gain from it?
What inspired it was, for the past 15 years or so, I've been facilitating a group to the National Alliance on Mental Illness. These are for family members who have loved ones struggling. And of course, in the various works that I do in talks and working in treatment and in private practice, is that there was common themes that would emerge in my work with these family members who were hopeless and felt helpless. And it became very apparent to me that there are some misknowledges, maybe lack of knowledge, misinterpretations, or these patterns that were existing. And my interventions in working with these families were also very consistent. And so, I'd get family members asking me if I have this written down somewhere, or can we have a copy of your slide presentation when I would present it. And it finally rang upon me to, why don't I need to put this down in some type of helpful manual? Because it was just these, what I call these gaps in knowledge of why these families were feeling stuck and they couldn't get help. And so that was the major impetus for it, basically based on need and gaps in knowledges and interventions out there that these family members just weren't getting. And so that's where I started to write it. When I did write it, it just literally were the conversations I had with these families. It was because it was so formulaic. And so it just was already in my head, didn't really realize it, that it was already in my head of how to write it, how to structure it. Because like I said, every group was very consistent in terms of the questions and the challenges and my interventions. So that's what it is to really help families feel hopeful, get unstuck, and realize that there is things that they can do. There's a different blueprint that they can use. Just realize that they just have to sort of change the strategy and plan.
I think that's a really needed source. I have a lot of female patients too. I have several who are sort of in this predicament, lost, and don't know what to do, who to ask. And that's another thing. It's like, who do you ask out there? Well, now we can go to your book. So
yeah, and there's interventionists that do good work. Interventionists are where you get the family together, you get the person struggling, and you try to convince them, let's get help. Where my book focuses all is the steps before that, is because what's really critically important is if the family unit isn't changing and evolving along with the person who's struggling, the chances of long-term success greatly are diminished. And that's what I see a lot. People can be in treatment for 30, 45, 90 days, 1 year, what have you. But if they're going back to that system, that family system, whether it be that spouse, that parent, the grandparents, and they haven't evolved in their own recovery process, whether it be communication, mental health awareness, taking self-accountability, then the environment is going to be a critical factor in whether it determines whether or not they'll be successful or not. So that's where I come in, is working with those families and sort of doing an intervention on them. Because there's a saying in the recovery arena, you didn't cause it, you can't cure it, you can't control it. But I say you've perpetuated in some form or fashion, even if you're coming from a good place. A lot of families I recognize, no matter how toxic their family environment is, they were coming from a good place. Doesn't mean you come from a good place is the best place and the right place. And so I address some of those issues as well. The term enabling, right? Enabling comes from a good place, human nature place, but it perpetuates the problematic behavior. If your loved one continues to lose a job because of their alcoholism and you continue to provide them a home and resources, where's the motivation to get healthy and keep a job, right? And so that's where I work with families on that level, is to help them recognize the all hand deck approach and that they need to assume an equal share of responsibility if they want change to happen.
So when you're in those groups, is it in the same room type of approach, or you take them individually?
It all depends on the arena. And when I was working in a residential treatment, we would have a big group with all the clients, families, members, and then you'd work with the client and the family, and sometimes with just the family. So that was on that treatment level. In the NAMI group that I facilitate, they're in a group, they're family members, minus their struggling loved one who come together as a group. And it's great because they support each other. Group dynamics, I think, are really critically important because you learn from one another. It normalizes you're not alone. What I find a lot, logically, our brain tells us we're not alone in this. There's a lot of people struggling. But when it's yourself, you feel like you're alone. You feel emotionally lonely that, man, but logically we know, there's other people like that out there. And so fellowship, group support are really, really critical important for people to navigate through this process.
That's fascinating, just looking at the structure that way. I just have to say, because I can imagine you see so many times where there's one individual with the set addiction and fingers are pointed at them. And it's up to them, right? And there's the enabling factor. But when you actually, it's kind of like epigenetics in a way. It's the environment we put ourselves in that allows us to heal. And even if it's good intentions, as you said, that it might not be the right. So that's fascinating. Thank you for that take home.
Yeah, we have this approach that the degree of someone's cause of pain is the degree of work they have to do. Well, you cause the most pain, so you got to do the most work. And that fails because the person that's trying to get better feels alone. They feel resentful eventually, and they feel like there's a power differential. Like, when am I going to get better? Well, you're not better. We can't trust you yet. We can't trust you yet. Or, or you've caused this much problems. And so it harbors guilt, and it's really, really self-defeating. And so what I talk about, I call the primary support system. And because not everyone's going to be appropriate, even if it's a spouse, the spouse may not be the healthiest person at that moment in time. And the primary support system are those people who are going to maintain the unified vision, who are going to stay hold to it, who aren't going to founder and give into emotions such as guilt and fear. And those are the people, especially in that first 30 to 90 days, that are going to be very, very critical. And so there's a vetting process that we do to see who's going to be on, I call the ship, of who's going to be part of that initial process. And so you're right, the environment, there's so much dynamics that go on. And in a good way too. I don't want to paint it in a negative way, but there's a lot of good things that the family unit can offer. And I've seen this disease, whether it's called depression, anxiety, whatever it may be, fracture families, demolish families. But through the recovery processes, I've seen families become closer together than they ever been before because of their recovery process that they're learning. So it's a really, really amazing process when you trust in it and it takes hold.
All right. Thank you so much. Do you have any final words of wisdom? It's never final. You're just a fountain of wisdom.
Well, if there's anything I want to tell family members are really have hope. I know it can be, you can feel very, very disempowered and hopeless, but I've worked with the most dire of cases, people who were suicidal, psychotic from their mental health condition, or substance abuse, homelessness, incarcerations, and people can get better and have gotten better. But what's really critically important is that the family unit has to be willing to engage and be a part of the process, but really know that the treatment process, and treatment doesn't necessarily mean going to a treatment facility. It could just there's some churches that have a protocol for helping people. What it is, when I mean treatment, is getting your loved one to a point where there's the only option, if they want to change and be a part of the family unit, is to accept help. And so I just want to impart, if there's a message there, is there's a good process out there that works, and don't give up.
Awesome. Do you want to say a word about your jiu-jitsu practice? It seems like it's a awesome thing that you're into. Tell us more about it.
Well, yeah. I've been training in Brazilian Jiu-Jitsu for about 6 years, and I can honestly say it has been a life and game changer for me, because it taps into all those 4 areas that I talked about earlier. The physical, the mental, the social, and the spiritual part. And it's number one, first and foremost, it's a great self-defense. It was designed for the smaller, weaker person to be able to manage or defeat a stronger, bigger person. And so it is because it uses leverages and submission tactics. And so it's great for a confidence builder for kids, women, adults, no matter what age, and the fellowship of it, the camaraderie in it. And it's the mat, metaphorically speaking. It is what it happens is you have to reprogram yourself every time you're on the mat. They call it the human chess game, where there's never one way of doing something. And every time you're on the mat, you are challenging yourself on all those levels to reconfigure and reprogram. And the mat it's designed for you to be uncomfortable and to be solution focused and to increase that threshold of discomfort. And so you get a lot of people from the military with post-traumatic stress disorder, women who maybe had some physical issues, maybe been assaulted, or people who were bullied, and kids. I have some kids who have autism. They're on varying levels of autism or ADHD. And so it's really important. I compete on a level, so I take it to a next level, but not everyone has to compete. But it's been a really, really big thing in my life right now that's really been a change for me.
So where can people find you, find more information about your work, your practice, your book?
Well, my book is available on Amazon and Barnes & Nobles and several other distributors. You can also find me on my website, drbrianlicuanan.com. I'm not sure if you're going to provide that below. So I have media appearances there, and you can buy my book through a link through Amazon from there, on Instagram at drlicuanan.com, and TikTok as well at drlicuanan as well. So those are the main ways to connect with me.
So awesome. So great connecting with you.
So great to connect with you both. Keep up your good work as well.
Thank you. We'll have you back.
I'd love to come back in whatever else and capacity. And like I said, this is my passion. It's what I love to do. And so keep up the good work as well.
Thank you for listening to this episode of the Soul of Medicine podcast, where science meets soul for whole health healing. Are you ready to reclaim your energy, vitality, and soul purpose? Then feel free to head to our website at kcorpusmd.com and schedule an appointment for your root cause review.